Good morning, my name is Martin Walsh and I am doing Module 6, the video presentation for the SBAR. I will be conducting my SBAR over scenario number 1. This is my physician, Miss Christine.
Hello.
So today our situation is Mr. O, our patient, 63-year-old male, became dizzy at home, at which point he came to the ED via non-EMS means. His wife transported him. Mr. O was subsequently admitted to the AMU with syncope. For background, he has been previously admitted to the hospital. He has been treated for congestive heart failure and acute myocardial infarction. He states he feels pretty healthy, although he does take daily NSAIDs for chronic back pain. Our assessment, Miss Physician. Mr. O was transferred from the ED to the AMU, the acute medical unit, at 1600 hours. He was assessed by Nurse Jenny, RN. His BP was 138/84, slightly elevated, stage 1. Pulse 76 and regular, which is completely normal, with a respiratory rate of 16. He is afebrile with a temperature of 98.6, and all labs are normal. During his transfer from the ED to the AMU, his IV was infiltrated, and Nurse Jenny relocated the IV site and applied a warm compress to the infiltrated site. At 21:30 hours, PCA tech notified Ben, the oncoming RN, that he just helped the patient come off the bedpan and noticed black tarry stools, and that the patient was complaining of stomach irritation. Then Ben, RN, assessed Mr. O, whose vitals had changed. BP dropped, it's now at 94/66, with a pulse rate increasing to 114, respiratory rate increasing as well to 24, but maintaining a good pulse ox of 97%. Mr. O is pale with clammy skin, and after patient notified Ben of abdominal pain, he is with a pain score of 6 out of 10. Ben noted a distended abdomen and diffused abdominal pain. So, Miss Physician,
Yes, sir.
we are recommending to conduct imaging such as a CT scan, MRI, or even an X-ray to see if we can note any gastrointestinal bleeding. The imaging, if imaging it's not conclusive on its own, we recommend a gastroscopy or colonoscopy for visual inspection of the GI tract. Recommended because bleeding in upper GI tract, such as a ruptured ulcer, can cause the appearance of black tarry stools. Meds that can cause tarry stools, such as bismuth-based meds and iron supplements, are not an issue, as patient only takes NSAIDs. Taking the NSAIDs does greatly increase the risk of ulcers within the GI tract. That's why we're recommending these courses of action. We also recommend to look for bowel ischemia, vascular malformation, or varices, which are large protruding veins located in the intestines. How does that recommendation sound?
It's perfect.
Perfect. Hello, I'm back again. I decided to make this into a 2-part video to allow my physician to go home. And previously, I've completed and read out my SBAR, which I will be including in the submission. But now we're going to address the 4 or 5 questions on the debrief of the class. This is something that, at first, I wasn't really sure what to expect. And by the time I finished, it was almost clear as day to me. So, to begin, our thoughts on the scenario. At first, I was overwhelmed. It seemed like there was a lot missing, or it was very choppy, and I was just getting a shotgun blast of numbers and information but with no clear delineation on how to use it or how it applies. And I just, line after line, just getting completely overwhelmed. I just didn't know what to do. But when I, used my S-bar, broke it down, and I could outline, okay, this part's the situation. This part was the background, or patient history. This part is what is going on right now and what we need to, discuss. And then this is what we need to do. It really took that big mess of numbers and information and opened it up. It made it much easier for me to see. And well, I know this S-bar is supposed to be for the reporting procedure to a physician if he's not there. I think this is going to be really helpful for, at least for me, in everyday life, where I can, say I'm an oncoming nurse, and my outbound nurse just briefly runs me through, and I'm not 100% certain on something, but they're gone, and everybody has an instance where a question arises later, so they are always they I don't know. Okay, so the inpatient or the inbound nurse briefing, it can be just like this, a little bit overwhelming. You think you have everything asked that needed to be asked, turns out that you didn't. Having this tool at my disposal, I will be able to look at all the patient notes, all the records throughout the last shift, and be able to basically create my own S-bar for me, so I know what we're looking at and what we possibly might need to do. Number two is what I think we could have been added to the S-bar. As I previously mentioned, I did scenario number one with Mr. O. He's the 63-year-old male admitted to the ED with syncope. Well, he was transferred from the ED to the acute medical unit with syncope, sudden fainting spells. And what I found wildly lacking was patient background. We have conscious, 63-year-old male with no indications of, mental impairment or unconsciousness. Yes, he did get dizzy and faint, but he walked into the ED with his wife. So you have two very good resources there. Having as far as your background and patient history of just, an MI and heart failure, and I take NSAIDs for a chronic back pain. That's wildly insufficient in my mind. As we look at our, my recommendations, I threw out a bunch of stuff, like the bowel ischemia, vascular malformations, protruding veins in the intestines that could have ruptured, or, but for me, the first thing I would have said is, okay, you're taking NSAIDs. For how much are you taking? Taking like a low dose, once in the morning kind of thing, or are you taking, up there near the clinical levels of, 2 or 3 800 milligram pills a day. So once we establish dosing rates, per day, second we need to figure out is how long. Okay, he says chronic back problem, but I've got a chronic back problem. It doesn't mean I've taken NSAIDs every day for the last 13 years. I mean, I take them, off and on, but if he's medicating daily with them, we need to know how long he's been doing that. And as you can see, I'm directing this towards all likelihood of a ruptured ulcer, usually stomach ulcer, lower end. But the other factor that was never asked or answered is alcohol consumption. And that's another one that greatly increases the likelihood of a stomach ulcer. If you combine, your NSAID consumption with alcohol, not only are you increasing your chances for a stomach ulcer, you're causing extra damage to your liver and kidneys. So if you're, taking massive doses of NSAIDs and drinking a lot, yeah, you could have a stomach ulcer, or there could be other reasons for the bleeding. The stomach pain, that could have been, hepatotoxicity, damage to your liver from the combination of NSAIDs and alcohol. We don't know, and since it was never asked or answered, that's something that I think we should all definitely be looking more for, for more of. Next was another thing that I think we needed in here was more detailed specifics on his current treatment within the ED and AMU. In that, so we see initially his BP is at 138/84, pulse 76, so it's normal pulse rate, normal respiratory rate at 16, and perfect temperature. So yeah, his blood pressure was a touch high, hypertension stage 1, but it's not bad. When that is at his point of the ED. After he's transferred, all it says is that his IV infiltrated, so Nurse Jenny started a new IV and put a warm compress on the infiltration site to minimize bruising. But what it doesn't say is just because they put the IV line in doesn't mean they hung a bag or they're running fluids or what kind of fluids. And I think that's something we should know. I think he's got a line in, but are they running 0.9% normal saline? Is it reduced to just barely dripping, or are we running wide open? And that comes into play upon Nurse Ben's reassessment after the complaint of stomach pain. When your blood pressure drops that much, first thing you want to do, pump up the volume. So if we have an IV line but there's nothing running, or it's just a maintenance strip to keep that from clotting up, then first thing I would do, open that line and get it running. Or if there's nothing even on it and we just have the IV in there, then I would definitely hang a leader right away and start bringing that blood pressure back up. So those are some of the things I think was missing. As far as excess stuff, I don't think there is anything. There's no such thing as excess to me. When I start thinking about passing on vital information, I think back to my military days. It's you want your situation report, size, activity, location, unit, time, and direction, but you will never get punished or berated for giving too much information, because no doctor is going to say, well, I only need 4 parts of the Chem 17, so don't even worry about the other stuff. You want to play with the full playbook, so I never think there's anything that we don't need in there. Let's see. If we did this conversation again, what should we do differently? As far as the video as a whole, I was honestly a little unclear about the direction, and I hope I interpreted this right and this is the correct answer, but some of these, the instructions were a little bit ambiguous. It says you need a friend who will serve as one of the roles in the scenario, but I hope my friend who is my physician, who I'm pretending to give it to, served the right purpose, and that's that's what you wanted to see. But I don't know. It was weird for me. Just the way it read. I don't know if she did it right or if I did it right. You know, I don't know if she was supposed to say something. It kind of threw me off. You know, she's not going to know. Oh yes, that's right. Go ahead and do this. You know, she's not going to so sit there. And then it says debrief the class, which I'm assuming was just continue talking to the video. And again, it's kind of confusing for me because I'm not debriefing in class. The class isn't saying this. It's, you know, I'm talking to you. So doing this again, I would like to see a little bit more, you know, clear, defined instructions and stuff like that. Do you think the significance of the situation was clearly presented to the physician? Yes, I do. Because so for me, when I ran through my recommendations with the physician on the phone, the one thing I did forget that you know, since I split this into two parts, I'm noticing now is that my recommendations to the physician at the time were, you know, conduct imaging like CTs, MRIs, X-rays. You know, it'd be more likely CT than anything because they'll give us the best detailed image of the GI tract and be able to help us look for bleeding best as possible. We, you know, we can do. I did recommend a gastroscopy or a colonoscopy, but that's, I mean, that can kind of be for an inclusive like CT because those are definitely much more involved. And when you have bleeding and, you know, the rate of loss of blood pressure like that and distension, you don't have time to sort of like to clear the guy out to go in through the colon. So I think the CT was the best option there. And then being able to, you know, being able to highlight the fact that he was bleeding in his stool, you know, the bloody tarry stool, which, you know, is definitely something very important. So I think the physician would know that, okay, you have a distended abdomen, blood in the stool, and BP's dropping, so he's leaking somewhere. So I think we did a really good job passing that recommendation on. But like I said, the one thing I did forget was, as part of my recommendations, to tell them hang a bag, normal saline, and run it full open. You know, so that way we can get as much fluid in there as quick as possible. That way we can at least bring his, you know, BP back to homeostatic kind of level. You know, get it right at maintenance. So that way he's not over respirating and over palpating in order to increase the blood, you know, the blood pressure. Because, you know, when you're working with less fluid, you have to pump it faster more often. So, yeah, I think we did a really good job letting the physician know what we need and why we need it. And yeah, I think it was pretty good for, you know, like I said, something I walked in confused on at first, and by the end of it, I think we got a pretty good idea. So I really appreciate it, and talk to you later. Bye.